Think Forward. Think Research Channel.
There's a structural problem with genocide, which is that it tends to happen in places that are off the beaten path.
So now, in order to promote nonviolence and reduce violence, ultimately we have to address the motivation.
Society needs to acknowledge that learning is a lifelong challenge.
The sit-ins challenge cherished beliefs most whites held dearly.
At the DNA level, we're all 99.9% the same. All of us.
So individuals do matter. And I think the quality of our individual leadership matters.
Who is speaking for poor people? 40 million Americans make $6 an hour. Who is speaking for them?
The only thing that one has after throwing everything overboard is the love that one can give.
David was a wonderful human being. He was extremely intelligent and exceedingly kind. In the fall of 1995, we sent him off to Harvard, full of hopes and dreams. And 3 years later, he came back in a coffin, the victim of suicide. David was never diagnosed or treated for anything. On the surface, he appeared to be a very laid-back and really very sort of level-headed kid. But I believe that he suffered from depression, and I believe he suffered from it for a long time, but he was able to mask it and to cope. In December of 1997, we got a call from his roommate who said that David had talked vaguely about hurting himself. When David came home from school for that Christmas vacation, we spoke with him very honestly about his feelings and our fears. We asked him if he wanted to see a therapist and see somebody right then and there at that time. And David, being the level-headed, logical thinking kid that he was, said, well, no, that would be silly. I'm going to be going back to school in 2 weeks. So we agreed, and he agreed that he would see somebody when he got back to school. When he went back to school, we called his housemaster, and we told him of our concern. We told him about what the roommate had said. We asked him to keep an eye out for David. He said he would. We really didn't know anybody else to contact. We were totally unaware of a process at the school to address our concerns. So we called David often. We went to visit him on Parents' Weekend. We thought that he was seeing a counselor. We know he saw him at least once or twice, saw someone. He continued to go to classes, he completed his assignments, he saw his friends. Then on the morning of March 15th, we got a call from the organ donation facility in Massachusetts asking us if they could use David's organs. And that is how we found out that our son had died. I think in the end that David was overwhelmed by feelings of hopelessness and ashamed because he wasn't able to fix himself. But he never stopped functioning, and he never broke down, and he never fell apart. And because of our lack of information and blinded by love and hubris, not our kid, not our family, and this lack of knowledge about any process, we were unable to take the steps we might have taken, and we didn't even know what steps those should be. For the last 5.5 years, I have thought long and hard about what might have happened and what, if anything, that we could have done to prevent it from happening. And I'd like to share some of those thoughts with you. I know that there is a depression assessment out there. I think I took it after David died when I first went to see a therapist, and I've heard about it from the American Foundation of Suicide Prevention and also the JED Foundation. I think it would have been a good idea if David would have taken this assessment in his high school years, maybe in conjunction with a PSATs as a sophomore or a junior. I think that all kids should take it, even if they're not showing any symptoms. I think that assessment might have pointed out some issues that David was having that were very much under the surface, that he wasn't even able to communicate properly. And at that time, he was living within a community of people, his parents, his siblings, his friends, his teachers, his doctors, who knew him very well and cared about him deeply and could have acted as a support system to address any of these concerns that might have been raised. Also, during that adolescent time, on any visit to a doctor, his pediatrician, maybe for shots or a school physical, I would have liked the doctor to have a discussion with David or with me or with both of us, or maybe passed out a pamphlet about some of the chemical and biological changes that go on in the brain at this time. Once again, passed out and spoken to everybody, even if there are no symptoms at that time. I think that the medical community needs to step to the forefront and take the lead in breaking down the stigma of talking about mental health issues. I think they've done a good job about talking about sex education and sexually transmitted disease and talking about drug and alcohol issues and drug and alcohol abuse. And I think they need to do the same thing with mental health issues, to normalize these, to talk about them often and openly with young people and their parents. Now, in terms of colleges and what they can do, I think that information on mental health issues should be given to every freshman in their packet that they receive at every school. And I believe this information needs to be in a form that's very concrete, that's honest, without being scary, and that is readily accessible, so it's there if and when you need it. In addition to the information, I think that every school needs to have a process or a referral system whereby if you do express a concern about a student as a parent, or if a friend expresses a concern, that student would then be monitored. For whatever reason, the kids coming to school today have more emotional problems, and the schools need to address these. And I do believe within any school community that there are many people, peers, teachers, counselors, interested adults that would step up to the plate and do something to offer these kids hope and help and love.
Inez, I really want to thank you very much for your very, very personal account. You take the discussion and shift it from data and from numbers to the reality of lives that are affected, your sons, yours, your husbands, your families. And I really appreciate that. I want to try to give you an overview of what we're seeing nationally in terms of student depression and student suicide. And the best way to do that is to report to you results from the American College Health Association National College Health Assessment. This is a random sampling survey. It involves a broad representation of different sized student populations across the country, involving 35 public and 9 private universities. Their overall sample size is 29,230 completed assessment surveys. So we really have a large body of students across the country talking about their experience of many different health-related behaviors. Within the survey, they ask very pointed questions about depression and suicide. I want to share some of the responses with you. One very important question is, within the last school year, how many times have you felt so depressed it was difficult to function? Well, the good news is that 55% said never. 28%, or more than 1/4, said between 1 and 4 times. 10% said between 5 and 10 times. 7% said between 11 and more times. So what we see here is that when you take these 3 groups who answered affirmatively or endorsed the question, 45% reported at least one episode of functional impairment as a result of depression within the previous year. 45%. Now, from the same sample, we see 10% acknowledged having seriously considered suicide during the preceding year, at least one time. 10%, 1 out of 10 of you may have had serious suicidal thoughts. 2% of the sample acknowledged having attempted suicide within the past year. Now, 2% seems like a small number, but when you look at the student body of University of Virginia and look at 2%, we're seeing that 375 students have likely attempted suicide during this past year. Now, that doesn't mean that all 375 show up at the ER or come to counseling and psych services, or anyone even knows about them. There are a lot of folks who do an overdose, they sleep through the night, they wake up the next day, and they go on with their lives. But we're talking about 375 lives that were significantly at risk during this past year. 12% of the sample had been diagnosed with clinical depression at some point in their life, and when we look at that group that had been diagnosed, 37% had been diagnosed within the past year, 24% were currently in psychotherapy, and 35% were currently taking antidepressants. The ACHA survey also asked about other disorders. They inquired about anxiety and eating disorders, and they found that 9% of the students endorsed having had an anxiety disorder within the past year, and 4% reported anorexia or bulimia, which are eating disorders. So when we look at what college students across the country are currently reporting about their mental health, clearly depression and anxiety are common experiences. Now let me go from kind of national data and bring this down to what we're seeing here at Counseling and Psych Services for the past academic year, 2002-2003. Here's a graph of our diagnostic distribution for the year. I've divided our diagnoses up into 10 different categories. And we have the affective disorders, which are your depressive and bipolar disorders, your adjustment disorders. And adjustment disorders, for those of you non-clinicians out there, are folks who are reacting to situational stressors, and they are struggling with symptoms, but the symptoms are in response to specific situational stressors. We have anxiety disorders. I think most of you know what anxiety is. Attention deficit disorders and learning disorders, eating disorders, substance use disorders, psychoses. And as you can see, this past year we had a very low incidence of psychoses, although that's not surprising. Usually folks who are so disturbed that they struggle with psychotic symptoms typically don't make it to university study. Personality disorders, other. What is other? Other are the groups of diagnoses that don't fit neatly into the other 9 categories. There are also the groups of folks who come in and within the first 2 to 3 sessions, their symptom picture is not clear enough for us to ascertain a diagnosis, and thus, at least in this data, they're counted as other, and they therefore may become diagnosed within the next week or 2 beyond, or within subsequent weeks after they've been accepted into treatment. And then there are the V codes. V codes are problems of life without clinically significant symptoms, and examples of V codes are students coming in because they're having academic difficulties, students coming in because they're having a struggle with a relationship or a boyfriend, or relationship difficulties with parents, but they don't necessarily meet clinical criteria for formal diagnoses. So those are V codes. Now, what's most striking about this graph? Obviously, depression, or the depressive disorders, the affective disorders, are almost twice as large as any other single disorder we have. Let's look at those depressive disorders more specifically. Within the affective disorders, we basically have 4 different diagnoses. There is dysthymia, and dysthymia is mild to moderate depression that is chronic in nature. It has a duration of 2 years or longer. There's major depression. Major depression is what we all typically think of when we think of someone with serious depression. We're talking about disturbances in energy, in appetite, in sleep. We're talking about acute dysphoria, crying episodes, suicidal thought, lack of motivation, lack of pleasure in daily activities. Those are many of the symptoms that you see with major depression. The bipolar disorders and depression NOS, and NOS stands for not otherwise specified, and it's simply the group of depressive disorders that don't neatly fit with the other 3. All right? Now with major depression, that is our most significant depressive category. 51% of the students who came to treatment last year met criteria for major depression. 6% represented bipolar disorders, 21% dysthymia, and 21% NOS. Now, if we go back here to our adjustment disorders, what you see is that 96% of those adjustment disorders were adjustment disorders with depressed mood. So those were adjustment disorders with depressive symptoms, which would really bump our percentage of depressive disorders up to 36% from 30. So 36% of the students that are coming to us with depressive symptoms. Very significant. Let's look very specifically at med students for this past year. We saw 54 med students. 38 of them were new diagnoses, meaning that the remainder had likely been seen in the previous year and thus were not given a newly established diagnosis in this past year. And of that group, we see that 10 of them met criteria for adjustment disorders, 4 for anxiety disorders. We had 1 personality disorder, 1 substance-dependent disorder, 7 were other. And then within the depressive disorders, we had 7 meeting criteria for major depression, 5 depression NOS, 2 dysthymia, 1 bipolar. We see that the affective disorders represent 39%. And if we look at that adjustment disorder, 5 of those 10 adjustment disorders were adjustment disorders with depressed mood, which moves that 39% up to 52%. So 52% of the medical students that we saw this past year came to us with depressive diagnoses. With the current distribution of diagnoses, particularly as it reflects the high percentage of the affective disorders, it is also resulting in increasing numbers of students requiring inpatient psychiatric hospitalization. Here's a graph of psychiatric hospitalizations of UVA students over the last 4 years. In 99-2000, there were 28. In 2001, we had 30. It jumped up to 37, and then it jumped up to 41. This represents a 46% increase in hospitalizations just over the last 4 years' time. Now, I can absolutely guarantee you, that managed care is not making it any easier for us to get students in hospitals. They're not lowering their threshold for hospitalization. All right? If anything, we come up against increasing obstacles from managed care to obtain adequate inpatient hospitalizations. So this truly does represent an increase of acuity within the student population. Now, 41 seems high, doesn't it? But let's look at the national data. Chickering Health Insurance is the largest single provider of university student health insurance in the country. They cover 87 public and private universities. Last year, they insured 254,561 students. They had 855 psychiatric hospitalizations. The national hospitalization occurrence rate for Chickering is 3.4 per 1,000, compared to UVA, which is 2.2. So, does 41 seem high? Yes, it does. Is it as high as the national average? No, it's not. We're actually below national average. So when you look at what's happening with students nationally, we also see increasing acuity across the country. All right, here's the $10 million question. Why? are we seeing such strong prevalence of affective disorders in the university population? Unfortunately, I don't have a $10 million answer for you. The complexity of intersecting variables that account for the prevalence of depression in the university population simply is not identified in a way that we can give an empirically based, clear and accurate answer. The reality is, I don't know why we're seeing as many depressed folks as we are. I do know that we are. And in fact, one of the things that is as yet unclear is, are we truly seeing more depression, or are we seeing depression that is identified at earlier ages, it is treated at earlier ages, and thus when we look at our kind of database and look at how many diagnoses we have, we see it increasing because we're doing a better job at identifying it. Is it truly there more? I'm not sure. Are our services in greater demand? You bet they are. My clinicians work very, very hard every week. So I really can't address the question etiologically, but I can address the question epidemiologically. If we look at the prevalence of depression in early and mid-adolescence and look at what is beginning to emerge between ages 10, 11, 12, and maybe 17 or 18, we then clearly understand why university counseling centers are as busy as they are. Two large epidemiologic studies. 1998, Clinical Psychology Review, Major Depressive Disorder in Older Adolescents. And again, in 2002, Journal of the American Academy of Child and Adolescent Psychiatry, The Epidemiology of Depressive Symptoms in National Longitudinal Study of Adolescent Health. All right? When you look at the combined results of those studies, they set the prevalence of adolescent depression somewhere between 10 to 30% of adolescents. It's a very high number. Now, not only is 10 to 30% a high number, particularly when you get into 30% range, but the relapse rates for adolescent depression are also very, very significant. The 2002 National Longitudinal Study, as well as a 1999 article in the Journal of the American Medical Association titled Depressed Adolescents Grown Up, present relapse data between 33 and 60%, so that those students or those adolescents who meet criteria for significant clinical depression, between 30 and 60% of them will experience a relapse of significant clinical depression. Not only are students coming to the university with a high prevalence of symptoms, students are coming to the university with a high prevalence of psychotropic medication prescriptions. Okay? In 2002 and 2003, we have two large epidemiologic studies that look at the incidence of psychotropic medication prescription. They both found a 2 to 3-fold increase in the prescription of antidepressant medication for adolescents over the past 10 years. 2 to 3 times. The reality is, many of these students who are depressed and who have pre-existing conditions and currently being treated are coming to the university. And we are trying to receive them, treat them, manage them. It's not an easy task. Now, specifically pertaining to some of the issues that Inez was discussing, I think the biggest dilemma that we face as university clinicians is the dilemma of confidentiality. Clearly, parents want to know when their university age children are depressed and distressed. I have a freshman in college. If my son were really struggling emotionally or psychologically, damn, I'd want to know. And I certainly wouldn't want to find out from the coroner's office or from the organ donor's office. I'd want to know ahead of time. Parents want to become involved when needed. They don't want to remain home passively uninvolved and find out about their students' struggles after the fact when it's too late. I think that was very poignantly represented here this morning. But at the same time, as clinicians, we struggle with both the legal and ethical limitations of confidential communication. And not only are there laws and ethics which kind of provide limitations to what we can disclose, but there's also, quite simply, the vital importance of confidentiality in conducting psychotherapy. Confidentiality is the cornerstone of successful psychotherapy. And the comparison I make is that it would be like trying to conduct effective surgery without an antiseptic field. It doesn't work. Psychotherapy doesn't work without confidentiality. Very frequently in the course of psychotherapy, students are sharing with me thoughts and feelings that they've never shared with anyone else. Very, very private concerns. Things that are frightening to them, things that they dare not acknowledge. And they need to believe that in sharing it with me, I am a safe container of that information. They can rely on me to hold it for them so that psychotherapy becomes a safe place to explore it. If I'm going to accurately track the level of risk with the students I'm working with, I have to have very accurate information. I need to know from them in a lot of detail what they're thinking, what they're feeling, what their behaviors have been over the last 2, 3, 4 days. And if I'm going to rely upon them to give me that accurate data so that I can make appropriate decisions, they have to trust that I will hold that data or hold that information. As soon as I choose to not hold that information, and as soon as I choose to notify others, then that trust is gone. And my ability to rely on the information they're giving me in order to help me to treat them, it's gone. It's out the window. So when I say confidentiality is important, I can't underscore that. It really is. And we can't conduct effective therapy without it. So how do we achieve a balance? How do we become responsive to Mr. and Mrs. Okrent, and at the same time treat their distressed son? Well, what we need to do is, in working with students, we need to shift the protection of confidentiality towards health-supporting communication. All right? Students come to me and they're help-seeking. They're health-seeking. They're not coming to me truly because they want to end their life. They're coming to me because they're frightened about those thoughts and they want help to not act upon them. The more I can engage them in that health-seeking behavior, and the more I can help them to recognize that at times involving parents or others within their close community is a very, very important aspect of their health-seeking behavior, that's essential. And that really is the work that we as clinicians have to focus on in helping students recognize that health-seeking behavior involves communication. It does not involve isolation or withdrawal. Unfortunately, it's not always possible. If it were, we might not be having this presentation today, but it's not always possible. I also want to bring in another issue here, which is sometimes, and I really want to underscore this word sometimes, involving parents prematurely is not necessarily best for students. Students are struggling with issues of separation and individuation during late adolescence. They're experiencing their own independence in their life. They're away from home. They're facing challenges that they've not faced before. And a very, very important part of that transition is managing those challenges. And sometimes part of those challenges are their own emotional and psychological struggles. And for them, successful growth means coping with and relying upon appropriate help to cope with those emotional and psychological struggles. Sometimes bringing in parents prematurely, in other words, having too low a threshold where we bring in parents, may actually not help a student towards their own emerging independence. It may have a regressive aspect to that. And we need to be cautious. And I'm not saying that we disregard parental needs, but I'm saying there's a delicate balance here. And the decisions we make with students really need to be made on a case-by-case basis. And we need to carefully look at what is in the best interest of each individual student, and then act accordingly. We should never experience the tragedy of a student suicide because our community is not responsive enough.